in the so-called neural retina, with a potential space between the two layers. The retina extends from the optic disc to the so-called oroserrate. Grossly, it may be divided into following regions, which we can see during the ophthalmoscopy, during the special examination of the fundus of the eye. Optic disc. It is a pale pink circular area of about 1.5 millimeters diameter, where nerve fibers pass through the lamina cribrosa to run into the optic nerve. Then macula lutea, or the yellow spot. It is a comparatively dark area situated temporally to the optic disc and the peripheral retina. Macula contains the thin sloping fovea and is made almost entirely of cones. It is the site of detailed fine central vision. One of the first lectures of the previous semester was devoted to the visual functions. And during this lecture, we discussed the two types of photoreceptors, rods and cones. And the difference in their position, in their function, and in their activity. And the central part of the retina is the so-called macula, which consists mostly of the cones, which are responsible for the high visual acuity, for the central vision, for vision in bright light, the so-called photopic vision. So this is a very important place. The damage of this place causes severe loss of visual functions like central vision, presence of the defects in the visual field, and so on and so forth. Visual acuity drops off rapidly in the perimacular areas. Peripheral part of the retina, the so-called oroserrata. It is the serrated peripheral margin where the retina ends. Here, the retina is firmly attached both to the vitreous body and to the vascular coat of the eyeball, the so-called choroid. There are a lot of diseases of retina. The main complaints of the patient are decreasing of the central and peripheral vision, degree of the defective vision, defects of the visual field, disorders of the dark adaptation depend on the localization and spreading of the pathological process. If the focus of inflammation or focus of dystrophy is localized in the yellow spot in the central part of the retina, it will be poor vision for far, poor central vision, presence of the central scotomas in the visual field. If the process is mostly damage to the peripheral retina, you will see the problem with the peripheral visual field, problem with the so-called scotopic vision, vision in dim light. But the central vision may be rather good, maybe even normal or subnormal. Tests of retinal functions include visual acuity examination, visual field examination, testing of color vision, and dark adaptation. Color vision is also depends on the normal activity of the cones. So the damage of the cones may cause the problem with color perception. And additionally, we can use such invasive methods of fluorescein angiography, which we use the special intravenous indicator staining, and then make photos of the fundus. And we can see clearly the different types and disorders of the angiopathies, pathological changes of the blood vessels of the retina. Additionally, we can use electrophysiological methods of examination, electroretinography, electroencephalography, electrooculography, different methods by which we can check the electrical activity of the retina and make a conclusion about the severity of the process in the retina, pathological process, and sometimes to make a prognosis for the development of the eye and for the recovery of visual functions. Different methods of ophthalmoscopy are widely used in case of retinal disorders. Direct and indirect ophthalmoscopy, biomicroophthalmoscopy, ophthalmochromoscopy. In case of biomicroophthalmoscopy, we use special lenses additional to the slit lamp examination to see binocularly the retina. In case of ophthalmochromoscopy, we use different types of light, different colors of light, green color, red color, white color, to examine the retina. Because in sometimes retina, if we use the normal source of light, white color, retina looks normal, but in case of in green color, in red color, you can find several disorders. Optic coherence tomography is widely used methods of examination of the eye, by which we can determine not only the presence or absence of the pathology, but the level of damage, the presence of the pathological process in different layers of retina, and so on. Among the diseases of the retina, the main forms are a retinal manifestation of systemic diseases. For example, endocrine pathology, especially diabetes mellitus. Cardiovascular disorders like arterial hypertension, atherosclerosis, and so on. Several renal disorders, several other endocrine disorders. All of them can cause changes in the retinal tissues, in the retinal blood vessels. And sometimes it's a sign of the severity of the systemic disorder. And in all the case of such a pathology, of course, our colleagues, endocrinologists, cardiologists, they ask us to check the fundus of the eye and to make a conclusion about the level of damage, severity of damage, and so on. And this examination also may be a sign of dynamic of the process, for the follow-up of the process, because due to the changes of the retina, we can change the line of management of such patients. Another group of drugs, a group of disorders which may cause changes in the retina are inflammatory diseases. Inflammation of the retina, or inflammation of the choroid, or usually we can see combined inflammation of both these structures, the so-called chorioretinitis, of different etiological factors. For example, of bacterial inflammation, viral inflammation, autoimmune inflammation, allergic inflammation, several types of specific etiological organisms like Treponema pallidum or tuberculosis, and so on. One more very large group dystrophies and degenerations of retina, which may be congenital or may be acquired. The most frequent type of retinal dystrophies is the so-called age-related macular degeneration. This is very serious pathology. A bit later we'll discuss it in details. And this is one of the main causes of the irreversible blindness in all the world. And of course, tumors of the retina is also a very important group of disorders, which may damage all the ages, newborns, young persons, and adults, elderly persons. Let's start with the retinal manifestations of systemic diseases. Here you see the retinal changes in arterial hypertension. As you know, a lot of people suffer from hypertension with its effects on arteries of the heart, brain, kidney, and retina. Essential hypertension is associated with thickening of the arterial walls caused by hypertrophy of muscle fibers in the media and by an increase of fibrous tissue in the intima. There exist a lot of classifications of hypertensive retinal changes. In Russia, we use this, made by Krasnov, which include 4 stages: hypertensive angiopathy, hypertensive angiosclerosis, hypertensive retinopathy, and hypertensive neuroretinopathy. So what is the difference between for this stage? And angiopathy means damage of only blood vessels. The mild, in form of mild narrowing of arterioles and broadening of retinal veins, small veins. Correlation arteries to veins is 1 to 4 instead of 2 to 3. Diameter, I mean, of course, the diameter of the walls. And additionally, we can see irregular diameter of the retinal vessels. So it may be thinner in one area and thicker in another area. And you see it's like changes in its diameter in different areas of the retina of the same blood vessel. And increased windings. So this is the first stage associated with the mild systemic hypertension. The second stage, due to the sclerosis of the arterial walls, the name of this stage is hypertensive angiosclerosis. We can see changes of the first stage, but more severe symptoms, and several additional symptoms. The so-called symptoms of copper wire and silver wire. It is an arterial reflex because of hyalinosis in the first case and obliteration in the second case. Symptoms of arteriovenous crossing is also typical in this stage. So-called symptoms of Salus and Gunn. The first grade of this symptom is characterized by narrowing of the vein on either side of the crossing. Salus 2 is characterized by deflection of the vein, and Salus 3, we can see a sort of break in the vein ophthalmoscopically by our eyes. Now, from here you see this symptom. This is the Salus 3, because this is the dark blood vessel, this is the vein, the bright, this is the artery. So here you see the area of crossing, and it looks like there exists a break in the vein due to this crossing. And this is the third stage of Salus-Ganz symptom or Salus 3 symptom. Hypertensive retinopathy. Consists of changes of previous stages, and additionally to the retinopathy and angiopathy and angiosclerosis, we can see hemorrhages, cotton wool spots, or the so-called soft exudates, and hard exudates. Additionally, maybe retinal edema. The deposition of hard exudates around the central part of the retina fovea may lead to a macular star configuration. So here you see narrowing of the arteries, as you see, very narrow artery, white veins, and here you see that the correlation is that arteries to veins is 1 to 4, 1 to 5. Irregular diameter of retinal vessels in different areas. If you look at, for example, this vein, you'll see that you see the thicken and or thinning of the diameter in different parts of the retina. Hemorrhages, you see them here, it's reddish dots, spots in different areas of the retina. Hard and soft exudates, these white points, it may be in form of small, it may be in form of small focuses with sharp borders, and it may be in form of large areas like cotton wool spots. This is whitish, edematous, without sharp borders. So combination of these symptoms are the signs of the hypertensive retinopathy. And depending on the position, localization of these focuses, there will be the problem with the visual functions. If you see the problem in this central part of the retina, it means that the vision will be rather poor. If there will be no changes in the central part of the retina, but only on the periphery, maybe problem with the peripheral vision in form of peripheral visual field disorders, but central vision will be rather high, even in the advanced stage of the systemic disorder. And the final stage of the retinal changes, the so-called hypertensive neuroretinopathy. Neuroretinopathy may present with symptoms of hypertensive retinopathy, previous stage, and additional changes of the optic nerve disc, as you understand from the name of this stage. What are the changes of the disc? Disc swelling. You see in these photos that there are no sharp borders of the optic nerve disc. Flame-shaped hemorrhages, not only on the retina, but at the disc edge. And the final stage may be atrophy, like on the right photo, atrophy of the optic nerve disc, when the disc is pale instead of pink. You see the small amount of blood vessels near the disc and on the surface of the disc. This is the final irreversible part of the disc damage. Swelling of the optic nerve disc is the hallmark of the malignant phase of hypertension. So if you see the swelling of the disc and you understand that these changes caused by hypertension, you can make a conclusion about the very poor prognosis for the patient life, because this is the unstabilized severe systemic hypertension. Such patients, of course, have decreased visual acuity, defects of visual field, but these are not the main problem with this patient, because in this case, the highest risk of damage of the brain, damage of the heart, irreversible damage with the risk of the patient's death. How to treat patients with the changes of the retina due to arterial hypertension? Of course, all retinal changes occur due to raised blood pressure. Therefore, first of all, their blood pressure should be corrected. And it's not our pathology, it's more therapeutical pathology. So our colleagues, therapeutists in family doctors, cardiologists, neurologists should treat such patients. We can just add several groups of drugs in case of advanced stage of retinopathy to try to decrease the retinal edema and try to recover partially the visual functions. So we can use drugs for protection of the blood walls, retinal walls. The special group of drugs, the so-called retina protectors, which can increase the survival possibilities of the retinal cells and increase the rate of regression of the corneal wool spots, soft exudates or retinal hemorrhages and so on. But the main treatment is treatment of the main systemic disorder, of course. The next very interesting but very severe systemic pathology which may damage the retina, diabetes mellitus. The prevalence of diabetic retinopathy is higher in insulin-dependent diabetes, about 40%, than in non-insulin-dependent diabetes. Diabetes, as you know, is characterized by sustained hyperglycemia secondary to lack of endogenous insulin. This is one of the most common causes of legal blindness in individuals between age of 20 and 45. Diabetic retinopathy is microangiopathy affecting the retinal precapillary arterioles, capillaries, and venules. However, large vessels may also be involved. Retinopathy has features of both microvascular occlusion and macrovascular leakage. Clinically, there exist three main types of diabetic retinopathy, or maybe more correct will be say steps of development of diabetic retinopathy. The first stage or grade, a background, or the so-called non-proliferative diabetic retinopathy. Then pre-proliferative diabetic retinopathy and proliferative diabetic retinopathy. So non-proliferative or background diabetic retinopathy. Ophthalmoscopic features of this type of diabetes include venous dilation and fullness, capillary microaneurysms, and retinal hemorrhages, deep dot and blot, and superficial, like flame-shaped in form. And the presence of hard exudates. They vary in size and have a yellow, usually yellow color with the sharp borders. Sometimes we can see mild retinal edema. So these are signs of non-proliferative diabetes diabetic changes of the retina. Non-proliferative means that there are no proliferative tissue, no neovascularization, means development of the new blood vessels. The second stage, pre-proliferative, more severe symptoms and high risk of development of proliferation. In this stage, changes are super added to the changes of previous stage, non-proliferative, and all the clinical changes are caused by retinal ischemia. So ischemia is the basic pathogenetic factor in case of diabetic retinopathy. Pre-proliferative diabetic retinopathy is characterized by the presence of intraretinal macrovascular anomalies, multiple cotton wool spots, retinal hemorrhages, and vascular changes, venous dilation and feeding. Severe macular edema is present in this stage. Approximately 10 to 50% of patients with pre-proliferative retinopathy develop proliferative retinopathy within first year after the diagnosis of proliferative stage. And the next stage, it's a very severe stage which causes the loss, sometimes irreversible loss of visual functions. And still up to date, the diabetic damage of the eye is one of the main causes of blindness in elderly persons. And sometimes even in young persons at the age of 20, 30 years old. So, proliferative diabetic retinopathy affects about 5 to 10% of the diabetic population. Neovascularization is hallmark of proliferative diabetic retinopathy. What does mean neovascularization? Development, growth of the new vessels. New vessels may proliferate on the optic disc and along the course of the major vessels, usually temporal vessels, elsewhere in the fundus. These new vessels may proliferate in the plane of retina or spread into the vitreous body. Later on, condensation of connective tissue around the vessels results in formation of fibrovascular epiretinal membranes. And vitreous detachment, vitreous hemorrhages may occur in this stage. And here you see the huge hemorrhage which cover the central part of the retina, inferior and superior quadrant, this photo. And of course, there are no possibilities to the light rays to get the retina, so the visual acuity of such a patient is very, very poor at the level of the light perception. Even finger counting for this patient at very short distance is doubtful. What are the tests for examination of the patient with diabetic retinopathy? This includes, of course, we should check the severity of the diabetes by urine examination, blood sugar estimation, and additionally use the fluorescein angiography, optic coherence tomography, ultrasound examination to find or to exclude areas of neovascularization, leakage, and capillary non-perfusion. Ischemia, as I remind you, ischemia is one of the basic pathogenetic factors of the development of the blood vessels and the growth of the new blood vessels with the severe complications. So to decrease the level of ischemia of different parts of the retina is one of the main tasks for our treatment. Medical treatment depends on the presence or absence of medical treatment depends on the stage. Of course, we should correct the level of the glucose, but it's usually the task for endocrinologists. They could use good diets, anti-diabetic agents in form of tablets or insulin. Of course, you know that in case of diabetes mellitus, one of them comorbidic pathologies, arterial hypertension, and there existed an additional risk of damage of the retina in case of unstabilized arterial hypertension on the base of diabetes. So to correct it is a very, very important task for the doctor. And local treatment in form of vitamins, enzymes, which can increase the speed of resorption of the blood, different types of the so-called angio-retina protectors in attempts to prevent the neovascularization and development of the connective tissue on the surface of the retina. But most, in especially advanced stage, most of these manipulations, this use of drugs are not so effective. The most effective treatment in advanced stage of diabetic retinopathy, in stage of pre-proliferative or proliferative retinopathy, is surgery in form of laser surgery and vitreoretinal surgery. Laser treatment or photocoagulation in form of panretinal or focal coagulation. Panretinal means which we coagulate all the surface of the retina, local or focal, only several areas. So laser treatment is indicated in severe cases of proliferative and in stage of proliferative diabetic retinopathy. Such a treatment, based on the burden of the eye in different areas, may reduce retinal ischemia. If you create scar on the surface of the retina by the laser instead of the area of ischemia, the risk of presence of ischemic factors in the blood, in the aqueous humor of the eye, will decrease, and the risk of neovascularization of the normal areas will decrease too. So this is the basis of the use of laser photocoagulation. Surgical treatment. Surgical treatment is required in advanced cases of proliferative diabetic retinopathy. Vitrectomy, procedure of removing of the vitreous body and of sort of cleaning of the surface of the retina from the debris, from the connective tissue. Vitrectomy is indicated for dense, persistent vitreous hemorrhages, tractional retinal detachment, and the so-called epiretinal membranes. Associated retinal detachment also needs surgical treatment, because even laser or medical treatment can't help patients in this stage. The next group of drugs, one more group of drugs which we use in case of diabetic patients is the so-called anti-VEGF. VEGF means vascular endothelial growth factor, and this group of drugs, anti-VEGF, which we use in form of intravitreous injections, help us to prevent the neovascularization by suppression of the growth factors for the blood vessels development. We use widely nowadays these injections, from 3 to 10 injections per year, sometimes even more, depending on the activity of the process. And the efficacy of this treatment is very high. We can get not only the decrease of the development of the process, sometimes even regression, decrease of the retinal edema, damage of this neovascular tissue with its regress, and recovery of the partial or total of the visual functions, even visual acuity and visual field. The minus of this procedure that it's temporal efficacy, and after several months, it's necessary to use the additional injections of the anti-VEGF factors, and of course, it's not. Sometimes it's rather expensive, and it's cause the damage, additional damage of the eye, may cause increased intraocular pressure or sometimes inflammatory complications. So it's more surgical procedure, and of course, with such a frequency, it has a risk of several complications. But sometimes this is the only way to help such patients. The next group of retinal disorders are vascular diseases of the retina. Occlusive disorders of the retina, of the retinal vessels, are more common in patients suffering from arterial hypertension or other cardiovascular diseases. Common causes of retinal artery occlusion are thrombosis, embolism, which may arise from large vessels of the neck, or it may be cardiac in origin. So not only local, but sometimes, sometimes systemic. Complication of systemic disorders. And may cause retinal arteritis with obliteration. Angiospasm is a rare cause of retinal artery occlusion, but also possible mechanism. It is commonly associated with amaurosis or blindness. Clinical features of arterial occlusion depends on the size and location of the obstructed vessels and the severity and duration of the obstruction. Patients' complaints of sudden pain usually we can't see because it's mostly the painless condition. But we can see acute loss, sudden loss, and profound loss of central vision without any pain, without any other complaints. If you check the direct pupillary light reflex, it will be absent. Here you see the photo of the patient with the acute arterial retinal obstruction. Ophthalmoscopy shows the following signs. The retina appears white as the result of cloudy swelling caused by intracellular edema. Central part of the yellow spot looks like a cherry red spot, and there exists such a symptoms, cherry red spots symptom. You see a dark area or a bright red area in the center of the edematous retina. Retinal arteries are narrow, very narrow. If you look here, you'll see that the veins are rather wide, but you can't see or see very, very narrow arteries. After a few weeks, the edema subsides and atrophic changes occur in form of retinal gliosis, development of the retinal connective tissue in the retina, and with the development of the optic atrophy. Treatment of major retinal artery occlusion is aimed at restoring the retinal circulation as quickly as possible by increasing retinal perfusion and dislodging emboli. Retinal tissue cannot survive ischemia for more than a few hours. Don't forget about it. The emergency treatment should include injection of vasodilators For example, atropine sulfate for injections, 0.1%. Different other vasodilators like felinum, acid-nicotinide, intramuscular, inhalation of mixture of 5% carbon dioxide and 95% oxygen is also possible to dilate the blood vessels and to prevent severe ischemic damage of the central retina. A lowering of intraocular pressure is also necessary for the same purposes. Treatment includes, not emergency, but other next stage of treatment includes vasodilators, anticoagulants, especially if you suggest that thrombosis is the cause of the ischemia, and steroids, which are also indicated in patients with Guyot cells arteritis, and steroids can help us to decrease the severity of the edema, retinal edema, and so on. The main complications of this condition is neovascular glaucoma, which may occur as a delayed complication after several months or even years after the acute central retinal artery occlusion. Neovascular glaucoma, yes, previous lecture was devoted to the different types of glaucomas. So you remember that increased intraocular pressure due to different reasons is the cause of, is the sign of glaucoma. The same situation here, due to the development of new blood vessels in the angle of the anterior chamber, there exists obstruction of this angle, and finally the increasing of the intraocular pressure with the development of all the signs of glaucoma, changes of the visual field, optic nerve disc, and irreversible loss of visual functions. Finally, we can see a patient with the optic nerve atrophy and absence of any visual functions. Finally means without treatment. Treatment can help us at different stages, but also depends on the time of the beginning of our treatment. You remember my statement that in condition of ischemia, retinal cells can survive only for several hours, not more. Okay, let's have a small break, about 10 minutes, then we'll continue with the next part of our today's lecture. Okay, let's continue our today's talk. And the next topic for discussion is retinal vein occlusion. After diabetic retinopathy, retinal vein occlusion is the most common retinal vascular disease. The predisposing factors include increase in age, patients in the 6th and 7th decades of life, systemic hypertension, atherosclerosis, diabetes mellitus. So as you see, some of today's topics which we have already discussed are the causes of this complication, retinal vein occlusion. Sometimes focal or general infection may also cause, like sepsis, pneumonia, may cause retinal vein occlusion. It refers to sudden complete occlusion of central retinal vein. It's characterized by marked sudden visual loss. Fundus examination reveals severe optic disc edema and hyperemia. Extensive retinal hemorrhages, you see them in this photo of the patient with retinal vein occlusion, one of the branches, superior branch of the retinal vein occlusion. Almost whole fundus is full of hemorrhages, here the superior part of the fundus, giving a splashed tomato appearance. So two symptoms: in case of retinal artery occlusion, cherry red spot; in case of vein occlusion, splashed tomato. Changes, enlargement and changes of the pathway of the normal pathway of the retinal veins, and numerous of soft exudates in form of whitish cotton wool spots in different areas, as you see here in superior part of the, in this photo, in superior part of the retina. Emergency treatment. Of course, control of hypertension, treatment of the diabetic changes, and anticoagulants, fibrinolizine, heparin, maybe high molecular heparin, different types of them. Treatment effective only if you start it in first hours after the sudden loss of vision. Systemic and local treatments. Treatment includes anticoagulants and protectors, spasmolytics, steroids, and laser photocoagulation to prevent neovascular glaucoma, as in case of arterial occlusion. In case of venous occlusion, one of the most severe complications is neovascular glaucoma. To prevent it, it's necessary to use photocoagulation of the fundus of the eye to create areas of burns with then scarring of these areas. If there exists a scar, there is no ischemia in this area. So we cause scarring, but we decrease ischemia and we prevent development of the neovascularization. Complications: neovascular glaucoma, as we discussed earlier, vitreous hemorrhages, and proliferative retinopathy. Inflammatory disorders of the retina. This may present as retinitis or pure retinal inflammation, chorioretinitis, inflammation of retina and choroid, and neuroretinitis, inflammation of the optic disc and surrounded retina. Rather seldom we can see the so-called periphlebitis, retinal inflammation of the retinal vessels, retinal veins. Sometimes we can see such a disorder as central serous retinopathy. It is characterized by spontaneous detachment of neurosensory retina in the yellow spot, which apparently appears in as macular edema. Etiology isn't known exactly. It is typically affects males between 20 to 40 years. The neurosensory retina is elevated due to collection of fluid underneath, owing to a defect in the retinal pigment epithelium. Patients complaints, dark spot in front of the eye. It may present with a sudden onset of painless loss of vision associated with positive scotoma and micropsia and metamorphopsia. Micropsia when all the surrounded world, all the object looks less than they really. And metamorphopsia, you see that the direct lines are not direct. They look for you, for the patient with this disorder curved. Ophthalmoscopy. Here you see the photo of the fundus of the patient with central serous retinopathy, and you see that edema looks like a mild elevation is in yellow spot, demarcated by circular ring reflex. Focus has a grayish color and different size. Central serous retinopathy is often recurrent. Don't forget about it. It often leaves small areas of atrophy and depigmentation. And of course, each next attack of central serous retinopathy cause more severe additional damage. Sometimes we can determine peripheral localization of the focus. Fluorescein angiography helps to determine correct diagnosis. Treatment depends on etiology, but we don't know exactly in most of cases the etiology. So we treat it due to these rules. We use corticosteroids. They can decrease the severity of edema, retinal edema, and strengthen the walls of the blood vessels of the retina. Sometimes we can use vitamins, especially group B, for neurosensory retina to prevent its damage and to increase survival. Then vasodilators to increase the exchange processes in this area. We can suggest that allergic component takes place in this, in the pathogenesis of central serous retinopathy. So antihistamine drugs are suitable for this group of persons. And in long-standing cases, we can use laser coagulation. Periphlebitis, retina or Eales disease. It is idiopathic inflammation of the peripheral retinal veins. It is characterized by recurrent vitreous hemorrhages. Etiology is also not known exactly. So you have a chance to become a famous ophthalmologist because the field of scientific research work is very wide, in case of retinal disorders. So if you want, you can try to solve all these problems. So it is a bilateral disease, typically affecting young adult males. The common presenting symptoms are sudden appearance of floaters in form of black spots, usually. What is your complaints? I see the black spots or flies in front of my eyes, the patient said. Or painless loss of vision due to vitreous hemorrhage. In the early stage, the affected veins are congested and show sheathing. Superficial retinal hemorrhages may be present near the affected veins. In later stage, recurrent vitreous hemorrhage may be associated with retinal neovascularization, one more disorder which is associated with neovascularization. additional to the diabetic changes. Complications. Proliferative retinopathy. So ischemia, neovascularization, proliferation. 3 steps of the same process. Tractional retinal detachment, proliferative tissue cause the shrinking of the retina and detach it from it in different areas. Then neovascularization of the iris, the so-called rubiosis of the iris, and neovascular glaucoma, one more disorder in which the neovascular glaucoma is a possible component, or possible complication. Treatment, oral and local steroids, sometimes anti-tubercular treatment, because tuberculosis may cause such a condition. Vitamins, laser photocoagulation, and in stage of complications, we use surgical treatment. Vitrectomy for the retinal detachment, anti-glaucoma treatment for neovascular glaucoma, and so on and so forth. Retinal detachment. It is separation of the sensory retina from the retinal pigment epithelium. Pathogenesis. In retinal detachment, fluid collects in the potential space between the sensory retina and the retinal pigment epithelium. Fluid may accumulate by 3 major mechanisms. It may escape from the vitreous cavity into the subretinal space through the retinal hole or tear or break in the retina. This tear is called rhomatogenose, or primary retinal detachment. Extravasation from the choroid or the retina may cause or may result in retinal detachment in the absence of a tear or traction, the so-called secondary retinal detachment. Lastly, the retina can be detached from its normal position by fibrous bands in the vitreous. We just several minutes ago, we discussed it in case of proliferative retinopathy due to diabetic changes, due to the Eales disease, and so on. Predisposing factors of the retinal detachment are high myopia, aphakia, means absence of the crystalline lens, maybe congenital, maybe acquired, different types of retinal degenerations, usually peripheral degeneration, also acquired or congenital, and trauma. Post-traumatic detachment is a rather frequent type of retinal detachment. Clinical features. Patients notice a localized relative loss in the visual field of vision, which progress to a total loss when peripheral detachment proceeds gradually towards the yellow spot. At the early stage, maybe photopsia. If you ask the patient, he will say, yeah, I see the flashes of light in different areas of my visual field. Or floaters, black spots, dots, flies in front of the patient eye. During the ophthalmoscopy, on examination, detached retina, and here you see detached retina on the periphery. Detached retina gives gray reflex instead of normal pink reflex and is raised anteriorly. This may be small or may assume the shape of balloons in large bullous retinal detachment. But the retinal blood vessels appear darker than in flat, normal retina. Retinal holes look reddish in color and vary in shape. They may be round, horseshoe shaped, slit-like, well, different types of retinal holes. Associated retinal degeneration and hemorrhages may be discovered. Visual field charting reveals scotomas or defects, isolated defects, corresponding to the area of detached retina. Ultrasonography confirms this diagnosis. Complications of the retinal detachments. Proliferative retinopathy, complicated cataract, opacity of the crystal lens, uveitis, inflammation of the eye, of its vascular coat, and phthisis bulbi. What does mean phthisis? Shrinking and it looks like a shrinking in atrophic globe of small size without any visual functions, and such an eyeball without any visual activity, it's usually inflamed and maybe a risk for the inflammation of the surrounding tissues for the another eye. So in most of cases, it's necessary to remove it to perform enucleation. Treatment, only surgical. There are no magic drops, ointments, injections which may treat the rhumatogenous or tractional detachment. Only in case of exudative detachment due to other pathology, inflammation, it's possible to use anti-inflammatory drugs to decrease the detachment. But in most of cases of in case of retinal detachment caused by in primary and secondary tractional, no ways, only surgery. Sealing of retinal breaks by different types of coagulation, cryo, low temperatures, or photo by laser, by producing aseptic inflammation. And bringing the choroid and detached retina near to each other by procedure of scleral buckling. An explant is material sutured directly onto sclera to create a buckle. As I said before, in case of exudative secondary detachment, the common causes can be grouped as systemic diseases, retinal hypertension, toxemia or pathological pregnancy, ocular disease like inflammation, vascular diseases, central serous retinopathy, which we discussed today, or tumors. It may be differentiated from a simple detachment by absence of photopsia, holes, tears, folds, and ultrasound examination can help us to differentiate between different types of retinal detachment. Tractional, as I said before, is associated with post-traumatic retraction of scar tissues, or in case of proliferative diabetic retinopathy, different types of other proliferative processes inside the eyeball. And this type of detachment is characterized by presence of vitreoretinal bands with lesions of the causative disease. Different types of surgery are used. Vitreoretinal surgery, when through the very small incisions we put the special microsurgical instruments inside the vitreous cavity and play the retina from inside. Or buckling of sclera, when we put the implant on the surface of the sclera with the same task to get the adhesion between the sclera and between the choroid and the retina, and to decrease the retinal detachment. And very, very important for not only for the eyeball, for the visual functions, but for the patient life, is a tumors of the retina. Retinoblastoma Retinoblastoma, it is a common congenital malignant tumor arising from the sensory layer of retina in one or both eyes. It is the most common intraocular tumor of childhood. Untreated, it is almost invariably fatal, unfortunately. It may arise in two ways. Sporadic cases as a result of somatic mutations. These are usually unilateral. And familial cases occur by autosomal dominant inheritance. Most of cases tend to be bilateral. And of course, if patient with retinoblastoma in anamnesis is going to become a father or mother, of course, you should discuss with him or her these risks. Clinical features, as several other tumors, retinoblastoma may be divided into 4 stages. The first stage, it is usually recognized at birth or between first, second year. Symptoms: yellowish white pupillary reflex. Here you see it. Normally the area of pupil looks black. Here you see it's whitish, yellowish. Maybe squint, deviation of the eyeball, and defective vision. Of course, there are no complaints in newborns at the age of 1 or 2 years. It's painless condition. Our small child can't say, I can't see, or something like that. It's difficult to check the vision only if it's a blind eye. Of course, you'll see that there is no fixation of objects and something like that. But it's difficult for the parents to understand it, especially in the first weeks after the birth. Ophthalmoscopy: tumor looks like a circumscribed polypoid mass of white or maybe pink or yellowish in color. There may be multiple growth projection into the vitreous body. You see the blood vessels on the surface of this elevated retina and so on. The second stage is glaucomatous stage, when there exists a severe pain, redness and watering. So in this stage, usually our small parents come to us because due to the severe pain, the child is crying, there exists a redness, watering, all the symptoms. It's clear for the parents that something is wrong. And so they come to us. Eyeball is enlarged due to the increased intraocular pressure. Conjunctiva is congested. I hope you remember from previous lecture the symptoms of congenital glaucoma. So the same clinical picture, but you understand that the etiology is different, and of course, during the examination, we can find the presence of tumor in the eyeball. Third stage of extraocular extension. The globe bursts through the sclera, and this stage, of course, is doubtful not only for the eye but for the newborn's life. And the final stage, fourth stage, stage of distant metastasis. Usually by lymphatic spread, maybe direct extension, or metastasis by blood. The target for the metastasis, distant metastasis, are brain, liver, bones, and lungs. 4 main directions. Treatment. In early stage, it's possible to perform enucleation to remove the eyeball to prevent the distant metastasis and growth of the tumor out of the eyeball. With post-operative radiotherapy, because it's malignant, very, very malignant tumor. And sometimes in case of a small tumor in early stage, very early stage, if it's possible, it's small size of the tumor, it may be destructive therapy with the help of radiation, with the help of photo, laser coagulation, or cryocoagulation. All these ways we use successfully, but you understand that the main condition for this is early diagnosis. And as you understand from my previous words, it's not possible in all the patients. Unfortunately, a lot of patients come to us, their parents come to us in the second and sometimes even third stage of the tumor development. Okay. That's all for today. If you have any questions, we can discuss them. If you have them, we can discuss them now, or you can write me in chat, or you can ask me or other teachers during our practical classes. If there are no questions, thank you for your attention and see you during the next lecture and during our practical classes. No questions. Goodbye, my friends. Goodbye. Have a good weekend. Bye.